and if you see food in the stomach after 12 hours, this is diagnostic as well for hypomotility disorders. General anesthesia mandatory. This is not negotiable. The sedation, it depends on what you know better and what your anesthesiologist knows better. Some people use medication that can loosen a bit the pyloric region. I do not want that because I do not want medication to alter the image that I have about the motility of and the contractility of the stomach. Patient positioning, as you see, always on left lateral recumbency, always, because this places the gastric antrum uppermost and the pylorus is more easily visible, except for the case that you want to place a peg tube in order to feed the animal. And this is done in light lateral recumbency. And sometimes we have foreign bodies, heavy foreign bodies, that we want to move a bit. So we put the animal in left lateral recumbency. We can rotate the animal, the patient, in right lateral recumbency as well, in order to move the foreign body. Hello from Romania. Hello from Saudi Arabia. I'm going to be, Ahmed, in Saudi Arabia in a few months. Adrenaline before the biopsy. No way. No way. Don't be so scared. No, never. So now let's go to real cases and see how a normal esophagus is, and also check what the pathology, a lot of pathological inputs in the esophageal area. So normal esophagus should be gray pink, flaccid. The lumen may contain some here so that I can see the lesions. So the lumen may contain some fluid, some foam. So don't be scared if you see a bit of some foam like this one or saliva. This is absolutely normal. So if you want the lumen to be open and to be inflated with more air, you tell your nurse to hold the cervical region of the animal. Your patient is already intubated, okay. And you may see, I'm gonna put this here again so that you can see, this is the pharyngeal sphincter here. So we're on the first third of the esophagus, okay. You can easily detect sometimes the indentation of the trachea due to the ET tube that you have put. Here it's not that much inflated in order to see the indentation. And when you reach the base of the heart, you will, here is the indentation of the trachea. And when you reach the base of the heart, you will see the heart beating. So you know where you are located. And we proceed to the lower esophageal sphincter here. Okay, the esophagus is very tough to biopsy, very, very tough to biopsy. I have challenged a lot of human gastroenterologists to do that, and they haven't achieved because they were, just mocking me. You can't take biopsy from the esophagus. And I said, you try it. And if you try it, I give you, free tickets to Dubai. I don't know whatever you want, but nobody succeeded. It's very, very difficult. I've tried, and I'm trying to actually take biopsies from the esophagus because I'm certain that there is pathology in the esophagus that we leave it undiagnosed. For example, in humans, in children, eosinophilic esophagitis is a huge issue. So could be in dogs and cats, but we don't know it because we don't biopsy the esophagus. So the pulsation of the wall mark the base of the heart, that you are adjusted to the great vessels and the heart. You can sometimes see the wave of paracelsus, and in dogs, the submucosal, this is a dog. The ones that I've showed you here is a dog. The submucosal vessels are not visible, as you may see, and I'm going to show you a cat, you will see the difference. except if the patient is a puppy. In some Chow and Shar-Pei breeds, you can find pigmented patches, just as in their tongue, and this is not pathological, okay? And in the cat, we have submucosal vessels that are visible, and also distal esophagus, we have circular folds. I'm going to show you. This is a normal esophagus as well, but I wanted to show it to you because it has these areas of dots. And this is a very, very frequent, this is not pathological, okay? This is a very frequent finding in senior patients, in geriatric patients. This is an esophagus of a dog as well. So you see these pigmented areas here. Let me see the question. Hi from Bosnia as well. Okay, so don't take it as a pathological sign when you see that, because a lot of people get scared. Okay, and this is the lower esophageal sphincter. And blood comes out of the stomach because I just have biopsied the stomach. Okay, so don't be afraid. This is not esophagitis or something that has to do with the esophagus. This is blood coming out of the biopsies from the stomach that I have just taken, because it's better to inspect the esophagus while you're getting out. And I tried, poor me, to biopsy the esophagus as well. I don't know if I succeeded in this case. Sometimes I do, sometimes I don't, but I always try it. Okay, and this is the esophagus of a cat. You see the vessels that are really, really prominent here in cats. You see how easily detectable they are in cats. In dogs, it's not the same thing. Can you see? These are the vessels of the esophagus, and these are the circular rings in the third distal part of the esophagus, just prior to the proximal to the lower esophageal sphincter. Okay, so in cats, if you see those rings, even if you don't know what this animal is, we don't write anywhere here what this animal is. This is a cat, okay? So let's go to talk a bit about esophagitis. And in esophagitis, of course, we have erythema, we have irregularity, we have a lot of erosions, and we have this entity that it's called reflex esophagitis, when we have a retrograde movement from the stomach into the esophagus. There are two kinds of reflex diseases in the gastrointestinal tract. The GERD, the gastroesophageal reflex disease, and the duodenogastric reflex disease. These two reflex diseases, both of them cause, the first one esophagitis, the other one gastritis. So in terms of the reflex esophagitis, let's see where the lesions are. Most of the lesions, I'm going to show you a very severe case here, and you can see that in circumferential, you see that this mucosa here is normal, and all the lesions are located just proximal to the lower esophageal sphincter, and the rest of the esophagus is normal. This raises a high suspicion of gastrointestinal reflex esophageal disease. Okay, and let's see that one. There is a point going from the esophagus to the stomach, which is called Z line. This is the Z line here. And some people misinterpret it for esophagitis. This is not esophagitis. This is the gastric epithelium, and this is the esophageal epithelium. And the transition between gastric from esophageal to gastric epithelium gives this image here. Okay, so this is a dog because we cannot see the vessels. This is the indentation of the trachea. Let me show you again how this is the on the roof of the esophagus in hour 12. Okay, you see the indentation of the trachea, And then you go into the gastroesophageal sphincter. Is this esophagitis here? Is this esophagitis? No, this is the Z line. This is the Z line. So don't misinterpret that. Okay. The esophagus is very much normal. Of course, the esophageal sphincter was open, and I don't like that because I want it to be closed. And you see that retrograding, that there is a lot of fluid retrograding from the stomach into the lumen of the esophagus, but and it stays wide open. You see, reflex disease, but it doesn't have any esophagitis yet. Will this dog proceed into having esophagitis? Highly, highly probable. Highly probable, unless it is out of the anesthetic episode. And this is not happening constantly. I don't know what kind of pre-medication we used in this specific case. Maybe it's because of the anesthetic agents. Okay, and you will see here, wow, this was a huge reflex from the stomach into the esophagus. This is how esophagitis, GERD disease is produced. Okay. Let's go and see. Okay, there are a lot of classification protocols for esophagitis. I mostly use either the Los Angeles one. This is extrapolarization again from the human medicine. I mostly use the Savory-Miller classification of esophagitis, and I show you here all the stages. For example, in stage 1, we have one or several just small erosions in one mucosal fold. Then in grade 2, we have several erosions, but they're not circumferential, as in stage 3. In grade 4, we have strictures, ulcers, and in grade 5, we have Barrett's disease, which is very common in humans, and it's precancerous. It's gastric metaplasia in the esophagus. Do we have Barrett disease in canine and feline patients? We thought that we didn't, but I will show you that we might have. Okay, let's see, now that we were talking about the gastrointestinal disease, the gastrointestinal, the GERD disease, the reflex, the gastroesophageal reflex disease. Let's have a look at a dog's esophagus, and you're going to say now, wow, the submucosal vessels might be, you know, a bit more prominent. Yes, because this dog has esophagitis. Okay, not in normal esophagus. This is the identification of the trachea. And here, if somebody was not that cautious, he would have missed the radiants of esophagitis, which are here. And thankfully, Aohua has the HBE enhancement, and you will see now that it's on. You've seen when it was off. Now that it's on, they're more visible. Can you see these radius of blood and of inflammation? So this dog has an esophagitis stage 2 that we would have missed without the hemoglobin enhancement, highly probable. Okay. You can see the radius of the esophagitis and inflammation. And let's go here. This is an amazing case of a cat. This is in the pharyngeal part of the esophagus, just right after the pharyngeal sphincter. And this is a stricture that is forming due to a doxycycline treatment. Even if you don't get anything out of this webinar, I want you to remember just one thing. Don't give cats a pill on a dry swallow, because it can remain in the esophagus for a lot of hours, cause chemical irritation. It has been proven that doxycycline and clindamycin can cause esophageal strictures, but other medications as well can cause esophageal strictures in a mechanical way in cats. So never give the cat's pills on a dry swallow. It has also been measured the amount of water that we can give them after the pill, which is 7 ml. If you just give the cats 7 ml of water, then the pill goes down and you don't have any problem, or just a small bite of food. It's very, very essential. And here we caught the ulcer because this cat was inappetent, very, very vocalizing, when great appetite at first, but when apprehending the food, the cat was vocalizing and she was doing this thing that actually was suggestive of a problem in the upper esophageal area. And a stricture was beginning to be forming. This is pseudomembranes. This is necrotic tissue because we took a biopsy from that. Okay. So please be cautious with cats. So now a bit about Barrett's esophagus. It's not something that you will encounter in your everyday practice, but I want you to know that, and I want you to have heard it even in one webinar, that it has been proven that we can have gastric metaplasia in cats. It was this cat, this was a paper from Dr. Rallis and his cooperatives. It was a cat, 11 years old, hyperthyroid with chronic gastroesophageal reflux disease, and also another Persian cat. I do not know if why both of these, and it has been more shown in Persian cats as well, with a lymphoma and chronic. The common thing is that both of the cats had chronic gastroesophageal reflux disease. Okay, so when we biopsied this tissue here, it was gastric metaplasia. It was not neoplastic tissue, but it was gastric tissue in the esophagus. And this is what Barrett's disease is. Okay, in the case of the cat shown in this cat, which you could depict by default, what we actually, yes, you could put a PEG tube, or more easily a nasogastric tube as a start. PEG tubes, we tend to use them when we have, a problem that needs longer standing solution. For example, if we have a chemo patient and they're vomiting and they cannot eat, or if we have a cancer patient, a patient that has tumors in the esophagus or elsewhere, and we tend to use the PEG tube for 8 months, for 6 months, we can just leave it for a longer period of time. For the ulcer to be healed in the esophagus, you will be amazed, and I will show you later some cases that it needs 3 or 4 days. So you don't need to put a PEG tube for 3 or 4 days. Okay. You can put just a nasogastric tube, but put it correctly. And I will show you, if anyone wants, I will show you the correct way of putting a nasogastric tube. Yes, I mean about the cat that had the doxy related. You don't put in these cats PEG tubes, no. If you want, you can, for your own practice, just to practice and placing PEG tubes, but it's not needed. Nasogastric tube for 2 or 3 days is absolutely fine. And let's go now to the esophageal strictures. Please be aware of what we talked about cats, because this is a huge problem. Cats tend to have strictures, and we will be talking in another webinar in depth about these strictures. You have a cat, it's admitted to your clinic for a simple procedure like neutering, okay, and 1 week later the owner comes and says, my cat is regurgitating, and it does not keep, they would say vomiting, not regurgitating. The cat will start vomiting and then regurgitating. because the lower esophageal sphincter is very, very loose after the anesthetic episode or during the anesthetic episode. So severe esophagitis has occurred. And as a consequence, up to 16 days after your neutering, the cat can actually form a stricture. And it has been proven. There are a lot of case series and a lot of research for these kind of strictures in cats. And the second most popular way of having an esophageal stricture in cat is pills. We have written an article published that even amoxicillin and clavulanic acid can cause, if not given properly, esophageal stricture through a mechanical way of the pill. And the capsules are even worse for cats. Okay, let's see this stricture in a cat. It is a cat because you can see the vessels. Okay, so we see esophagitis here. And we're reaching up to a point. What do we hear that we cannot proceed? You will see a bit further. In strictures, we have a circumferential narrowing of the mucosa. We can have esophagitis, and here we are. You can see how broad the esophagus, the lumen was. I have to stop it here so that you can see how broad the esophagus was and how it has narrowed down. And you can measure the stricture with your forceps by opening the forceps. Not even the forceps could pass through this diameter. This small, this stricture was. Okay, so most of the times when the cats are submitted to our clinics, they don't have esophagitis because the fiber tissue has already been formed. They have passed the stage of esophagitis. So now the tissue is fibrous, it's very, very firm, and there's nothing to be done rather than balloon dilations up to this point. Okay, so intraluminal causes of esophageal stricturing could be gastroesophageal reflux disease. This is why after your neuterings, always ask the owners, is the cat hypersalivating 3 or 4 days after your operation? And cats, when they feel nausea, they do this extension of the neck. They just stab it because this is painful. Esophagitis is a real painful situation. And they go like, they're extending the neck. If you see that, please suspect esophagitis and try to give medication that will prevent esophagitis and esophageal stricture. Otherwise, they will end up with a stricture. Okay, drug-induced, we talked about that. Foreign bodies, of course, and neoplasia can also cause a stricturing. I'm going to show you some cases of all of those things. This is a cat here with reflux esophagitis due to an anesthetic episode. And this is 1 week after the neutering. Will this cat have a stricture? Yes, if we have left it in its own fate, it would have had a stricture. Yes. So you see the kind of esophagitis, circumferential, stage 3, because all the gastric fluid has come into the esophagus. And we got into the stomach. It actually has started to form a ring. This is why I'm going back and forth with the tip of the scope in order to open it, and then we will give medication in order to prevent it. Okay. And you see that the further up we go, the better the esophagus looks. Of course, this cat has vomited throughout the base of the heart. So there are lesions because the reflux disease has been up to the base of the heart. There are lesions up to this point. Okay. And of course, there are extraluminar causes of esophageal stricturing, like a persistent right aortic arc, like here. So the esophagus is entrapped at the level of the heart, and we have megaesophagus. And anterior mediastinal lymphoma, anything, I will show you a case, anything that can strangulize, that can actually entrap the esophagus exterior, extraluminarly. And this is how it looks. This is a 3-month-old German Shepherd. This is how it looks. The esophagus cannot be inflated. You cannot see the lumen. And you feel that this is not the kind of stricture that you get, you know, intraluminarly with a fibrous tissue, but it's something from the outside pressing the esophagus. And please be aware, because some people miss the diagnosis of persistent right aortic arc, because sometimes there are reports of late onset. We had cases that were 2.5 years old and 1 8 years old with chronic regurgitation, and they had persistent right aortic arc. So don't be confused if you see an adult dog, and always, you know, have your medical criteria on the line first, and then the books and what the textbooks say. Medicine is not in the textbooks. Of course, you have to know all the information, but it's you who process the information. How do we dilate? How do we make the dilation? There are a lot of ways, by boogies, by balloon dilation, and with the tip of the endoscope, if it's a very recent stricture. I prefer balloons. I've never used the boogies. Please do not use I've seen dilating strictures with a range of things. Most commonly with ET tubes, you cannot control the pressure of the cuff of the ET tube, and sometimes this causes rupture of the esophagus. So we definitely have to use the balloons, the proper equipment, the proper instrumentation in order to do a procedure. Maximum procedures I've done in kittens 14 dilations in order to, in some kittens, very small kittens, 14 dilations. And it used to be once every week, once every 10 days in the textbooks. Now this is changing. You have to do it before the ring reforms, which is every 2 or 3 days. So you put the balloon in the stricture, you inflate it. It's a radial stretching, which is less traumatic than the ET tube, for example, and you can control the pressure. The balloon should be at least 10 centimeters long. My balloons are 10 centimeters long, so that it covers the whole length. Always look for a second or third stricture down the esophagus lumen, because sometimes you open one stricture and then you go and there's another stricture as well. They can be put through the scope or sideways. I always put them sideways. You will see now how I do it. A 20 millimeters balloon is a universal balloon, which is the most useful size. Of course, I have all range of sizes from 6 millimeters up to 35 millimeters. It depends on the size of the ankle and the stricture. And inflation with water, rather than you can inflate air, you can inflate water, but it's better to inflate air for the safety of your balloon. Okay, let's see the esophageal stricture in cat. This is the cat that I've shown you earlier. Okay, so we reach up to a point where the esophageal lumen has no width at all, and you either have to do it or, you know, then it's esophageal surgery, which is not good. Esophageal surgery causes more stricturing, actually, after that. And most of the times we succeed with the balloons. Okay, so we reach up to this stricture here, and this is what we did. So we put the balloon in the center. Even that is a bit difficult. If you do it sideways, it will go all the other ways rather than the way that you really want it. So you put it in the middle, you put all your balloon throughout the length of the stricture, and then you start inflating. Once you're safely in the position, then you start inflating it, and then you leave it for around, I leave it for 30-40 seconds sometimes, and even more. What medication should be appropriate for esophagitis? Yes, I'm going to show you all the medication. We're going to talk about the medication. Do we need additional machines for balloon inflation? No, we just inflate it with a syringe. It's not a big deal of an air. Yes, you inflate it, you pre-inflate it outside the patient so that you feel that it's distended to its fullest. Okay, and then you know how much air you need to put in, you deflate it, you put it in the patient, and then you inflate the air, the amount of the air that you have inflated outside the patient. About about the esophagitis, we will talk a bit later. Okay, let's see the result of our dilation. Let's see what we did. Now what I'm doing is that, can you see how much tearing of a tissue here? I have, this was the very, very small, tiny hole, and we have now enlarged the diameter. We have augmented the diameter. And what I do is that I instill xylocaine gel. It's 1 to 10 with saline solution, because this is really, really painful. And I want my cat to not to feel anything. I want the esophagus to be numb. So I put xylocaine throughout the, you see, throughout the length of the ruptured, of the dilated stricture, and then throughout the length of the esophagus. Okay, this cat came 3 days later with this huge esophagitis that we have caused it. Okay, let's see how the esophagus has healed. And has the stricture been reformed? Yes, the stricture has been reformed and we had to dilate it again, but not, you know, in the initial form. This was easier this time. We have caused all this rupture now with a bigger balloon. Now this time we got in with a bigger balloon, and you can see the rupture that we caused. It's very, very, you know, when you see it, you say, oh my God, I have ruined the whole esophagus, but the esophagus is healing so good in 2 or 3 days time. And now what I'm doing, this is why you see this blurred picture, is that I'm taking my scope in and out in order to keep the length of the hole that we have caused. So we have caused that, okay? But this is going to heal. We don't care. This is going to heal. You can see the damage. If you don't cause that, then you will never open the stricture. This is the kind of tearing that we need. Without X-ray, Diane, please explain on that. Yes, we do the balloon dilation without an X-ray, with endoscopy. We do it with endoscopy. We don't need an X-ray. If you mean barium study, yes, you can do that, but then you will need a lot of days. You will always do your barium after your endoscopy, not before your endoscopy. Okay, so 3 days later, we did the second dilation. Let's see what happened with this poor cat. And then 7 days later, third dilation. You see that the esophagus is much, much better. Pinker. And let's go and see now. You see how this is only 4 days later and it has healed. You see how well it has healed, this huge rupture that we've caused. It has healed and it starts forming again a fiber tissue here. My God, you see, it has healed and it starts in 4 days time. So if you leave it 10 days, then you will see your initial length. So this was the 3rd session, and let's see our result in our 3rd session. It's very, it needs patience, and it needs for people to actually pay for these procedures, for the owners to pay these procedures. These can take up to, 14 sessions. And this is not something cheap. These are expensive procedures. So now we have ruptured again. I'm not showing the balloon dilation because it's the same thing, the exact same thing. And the result is that we have caused, from this diameter, we went up to all this tearing up of the esophagus as well. Again and again and again, every 3 or 4 days. You might need 7, 8, and we get into the clinically now. This cat was much better. She could swallow canned food without even putting it in the blender. But we had to do the procedure, even though this cat was not regurgitating. Hello from Romania. What kind of food? That's a good one. I tend to, in these patients with severe esophagitis, we tend to give something, that it can easily be melted. AD would be, one option. Or ID, but blended with gastrointestinal, not only ID, maybe, the Royal Canine clinical diets as well. I don't mind any clinical diet that can be used with warm water as a start, canned food as a second stage, and then dry food. Now, in terms of esophagitis, do you use cortisone after each, not after each dilation, but yes, at this site of the, stricture, we could instill with the needle that I have shown you earlier, we could instill cortisone peripherally. Okay, and we also give cortisone after, even if you have such a severe esophagitis. Now, the treatment for esophagitis, first we give a PPI inhibitor like lansoprazole or omeprazole, and then on an empty stomach always, then we give sulcrafate, of course, sulcrafate. Sulcrafate is the A and the Z of esophagitis. So first, the correct order is PPI inhibitor, pantoprazole, lansoprazole, esomeprazole, whatever you want. Then half an hour later, we give sulcrafate in a syrup form, not in a tab form. In a tab form, it doesn't work. Okay, and then we give an antibiotic for some days because we have caused a severe inflammation in the area due to the balloon dilation. Most of the times we do it like in amoxicillin and clavulanic acid. It would be better if you did injections, but with cats and injections, this is a bit, I try to avoid a lot of injections due to the to the feline injectional site sarcomas. So the less injections they have, the better it is, because it's not only in vaccinations. Okay, it has been proven that even cortisone injections or antibiotic injections can cause local sarcomas in cats. So this is pretty much, and also we give prednisolone in very low dosages, like 0.3 milligrams per kilo, or anti-inflammatory dose like 0.5 milligrams per kilo. And we always inspect the patient in 3 to 4 days time. We always do that every 3 to 4 days. Okay. Yes. With the gastroprotection, we gave, yes, we gave cortisone as well. And let's see. A case with a dog now of a stricture. And this dog suffered from an open lower esophageal sphincter, which actually, this is the stricture here, as you see, the esophagus was hugely broad, just behind proximal to the stricture. And as you've seen, there was a ring formed as well. And this is the stomach here, and this is fluid, gastric fluid from the stomach. Okay. This is really, really bad. And let's see what we did in this case. So we go into this, it's all fluid coming from the stomach, gastric fluids. You see how it retrogrades from the stomach into the esophagus. This is why this was actually formed. This is a very, very nasty case. And you see that the lower esophageal sphincter, you cannot tell the borders between the esophagus and the stomach. It's all open. It's like the same lumen. The esophagus just goes into the stomach without a sphincter. And this was the dilation procedure. This is shown better than in the cat. So we dilate the balloon. And we wait there, dilate it, dilate it, dilate it, and dilate it. We just stay. You see for how many minutes? And I try gradually to distend the balloon. And then the next time I use bigger balloons in diameter so that we can keep a very safe for the animal diameter in order to be functional, in order to be able to eat. Okay. And then let's see what we have caused. Sorry. Can you hear me now? I think that my connection is a bit. Let me see what I can do. Okay, and can you hear me? Because I cannot start. Oh, thank you. I will solve it. Just give me a second and I will solve it. I will share screen again. I'm sorry, I will stop sharing for a while so that I can reshare. Give me just 1 second, because my PowerPoint is not responding for some reason. Okay. One second and I'm back. Okay. Share screen again. Okay, good now. And this is the kind of tearing that we caused with our balloon. Okay, this is huge here. You can see, can everybody see me now and see my videos? Please answer to the chat. Thank you, thank you, thank you. Thank you for confirming. Okay, so you can see how huge of a tearing that was. And we go back and forth with the scope. This is really, really scary. If you see it in a picture, you can see how much of a tearing this is, how big of a tearing this is. Okay, now we're back. And you can see that the rest of the lumen has a very normal mucosa as well. So esophageal foreign bodies, we're going to have a separate webinar for the foreign bodies, but I always want you to check your cats. When a cat is coming drooling into your practice, you might see that they have under the tongue, and you have to sedate the cat in order to see that, strings. This is a very, very common foreign body for cats. For cats, esophageal foreign bodies are less often than gastric foreign bodies. Rather than strings and needles and some fish hooks. And the common location for all foreign bodies are the thoracic inlet, the heart base, and the esophageal hiatus, where the esophagus is narrowing normally due to its anatomy. Okay. And you always have to be aware of the hair balls, because they can be very, very nasty foreign bodies embedded in the esophagus. In dogs, there is a predisposition in terrier breeds, of course, most commonly bones, toys, hooks and toothpicks. The hooks are, a bit difficult. I'm going to show you a lot of cases and a lot of tricks and tips how to remove hooks in the webinar that will follow in the next months. And this is a bone here. Bones, if you cannot retrieve them, advance them in the stomach. First of all, it's easier to do a gastrotomy than do an esophagotomy. And secondly, you will never need to do a gastrotomy, because the bones can be digested. We have done it so many times, and we have actually followed these cases. None of these dogs had to undergo a gastrectomy or a gastrotomy. So we always assess the esophagitis after we remove the bone. And you can see here, this is the bone in the stomach. Okay. And we don't care about the bone. You see that there is a severe esophagitis, and we have to take care of that in order not to form a stricture. And we inform the owners each and every time. We tell them that if you see the dog regurgitating, you bring it right away, because a stricture might be formed. And of course, we give all the esophagitis treatment that I have told you about. Okay. And this is an overtube for very, very sharp objects. I'm using the overtube. The overtube is this tube here. And then you put your endoscope through the tube, and you can advance the bone in the overtube so that you can put it safely in the overtube and bring it with your scope and with the overtube outside. You see how with rotatory movements, I'm bringing the bone in the overtube in order to grab it out. Okay. And sometimes, this is another point that I want you to take as a take-home message. Sometimes we have some foreign bodies in the esophagus that shouldn't be there. For example, a piece of fish, which is very soft. Why should a piece of fish or of meat be in the esophagus, just lying there, staying there? This is actually a fruit piece, but you see that the esophagus is not, it's not embedded in the esophagus. It's staying right there without even proceeding into the stomach. And let's have a look at this one. This is actually soft food there. So you will be a hero when you just shove this foreign body in the stomach because it's food and it's going to be digested. But don't leave this patient go home without a proper diagnostic procedure. This is, very soft. I thought when I saw that, I said, what is it? Is it a bone? Is it something hard? So we put in our forceps, as you will see, and it was very, very soft. It was dry food, and it was just there, lying in the esophagus for no reason. Check these dogs for underlying hypomotility disorders. Don't send these patients home because they will come back with another foreign body that could be more dangerous. They should be checked for Addison's disease. Actually, this dog was a Boston Terrier with an Addison disease, and it had this very, very small, it was either a piece of fish, something, or a piece of pear in the esophagus. Check them for hypothyroidism. And also there is a disease called the immature esophagus of Westie, West Highland White Terriers, that up to 1 year old, they're regurgitating, and then because of immaturity of their esophagus. And sometimes you just take an x-ray and these dogs have megaesophagus with no reason, and they don't even regurgitate sometimes. The owners haven't even noticed that. So please beware of these patients when you see something like an abnormal foreign body. So you see that we preceded the forceps and that it's very, very soft. It shouldn't be there. It shouldn't have stayed there in the esophagus. Okay. And what about megaesophagus? I've told you that this is not the way to diagnose. Endoscopy is not the right way to diagnose megaesophagus. So just for educational purposes, you see the fluid. This is a megaesophagus in the dog. You see the fluid in the esophageal area, just standing there without proceeding. These patients could have a very, very hard recovery. Okay. Thin mucosa, the submucosal vessels in the dilated esophagus could sometimes be visible. We could have or not have esophagitis. Okay. And let's see that one. This is just dry food in the esophagus with a very flaccid esophagus. And check this out. Even the pellet, this pellet is shown here in the blue arrow. This is amazing, the photograph. Okay. But this is not the correct way of diagnosing megaesophagus. A plain radiograph, lateral radiograph could easily diagnose it. And then you have to find the underlying reasons for the megaesophagus. This is a very good one. You might encounter sometimes these nodules in the esophageal area. These are lymphoid nodules most of the times, and they are suggestive of food allergy. I tried to take biopsies from this animal. It wasn't possible. From other animals, it has been proven that it was food allergy as a component in these nodules. This is not Spirochaeta nodules, okay? Spirochaeta nodules are totally different. And here, as we finish the scoping, now trying desperately, you see the nodules all over the esophagus, here as well. Okay, and let me see if I can see the point of strangulation, because there is a point where the esophagus is a bit here. You see that there is a point here that the esophagus is extraluminarly strictured from the outside. So we did a CT scan, and this animal had the esophagus was compressed by the cervical muscle, which was very, very thickened and inflamed at the level of A5. And actually, this dog had undergone, it could not swallow. It was regurgitating all the time, just because of this strangulation, just because of this extraluminal compression. And this had undergone myotomy, which was very helpful. And this is a very, very amazing case. You will see gastroesophageal intussusception. So I'm scoping this animal. Oh, sorry. And we're finishing just these two last cases. So I'm scoping the animal and I see this mass in the lumen of the esophagus. And I say, what kind of a mass is that? We should biopsy this mass. Is it an esophageal mass? You see that the walls of the esophagus are really, really thin. You can see through them. Okay, a lot of fluid, esophageal reflux disease. Okay, let's proceed with the endoscopy. And you will see something really, really fascinating happening. A lot of foam. So we say, okay, let's just clear the picture a bit. Let's put some water and make the picture. And I'm starting to having an idea of what this might be because of the rugae that I'm seeing. So all of this is a stomach into the esophageal lumen. So I go into the stomach now, and you see that the minute I inflate the stomach, all the stomach is coming out of the lower esophageal sphincter. This was a dog that was regurgitating for a long time, and it had herniation, hiatal hernia. And the minute the hernia was corrected, then it didn't regurgitate anymore. So the predisposing factor are megaesophagus, esophageal dysmotility disorders, and laxity of the esophageal hiatus. And the last one is what this animal had. And once it was corrected, this dog has been regurgitating for 3 years. For 3 years, they cannot accept a patient undiagnosed. And our last case is about esophageal neoplasia. Of course, in senior dogs, we can have sarcoma, fibrosarcoma, osteosarcoma, squamous cell carcinoma. In these patients, for example, in this cat, one of my colleagues asked me later about PEG tube. Yes, in this cat, you can do 2 things. You can either put a stent, an esophageal stent, as a relief in order to keep the lumen open, or, and we biopsied this, and it was sarcoma. No, actually, this was squamous cell carcinoma in the cat. And you can either put a relief stent, but it's only going to be for a few, for a while, up until the proliferative tissue goes through the stent as well. Or you can put a PEG tube as well in order to preserve the body condition score of the animal. This was a very, very nasty case. Otherwise, you don't have any other choices in these patients. You will euthanize them. That's pretty much everything. Thank you very much. That was my favorite slide from Aohua. Whether it's a dog or a lion, whatever it is, we cure it. I think that the vet profession, the veterinary profession, is one of the most amazing professions in the world, and the way we interact with each other. I think that we have an amazing occupation and interaction with each other. The human doctors are not like that, believe me. Let's see a bit of Jason, you can take over if you like. I'm so sorry for the technical problem that I had with one of my videos.
Well, that's okay. Thank you, Dr. Vasiliki. Thank you for your brilliant presentation. And if you have further questions, please contact us on Facebook, YouTube, LinkedIn. Okay, today's webinar is over. Thank you. Hope you enjoyed today's webinar.
Thank you, everyone, very, very much. I can't see any questions that I haven't answered. Greetings to all the countries, to Bulgaria, to Switzerland, to Cyprus, to Greece, to everyone. And I hope to meet you soon in person. Most of you to Saudi Arabia. I'm sorry, I'm biased, so positively biased towards Saudi Arabia. I love the country. I have visited it a lot of times. All of you, and I'm always available for any questions that you might have, any cases that you might have and you want to ask me, always available. Thank you.